To kick us off, I want to invite Art Jones from Health Management Associates to come on up to the stage. Sir, welcome. Thank you. Oh, that's right. You got a cold. So we just practically kissed, but we won't shake hands. So let me just start with that open-ended question. What are you spending your mental energy on? Not necessarily related to clients directly, maybe, but not necessarily. But when you are sort of intrigued and have extra time to spend on a healthcare challenge, what is it that you spend your time on?
Yeah, so I think we have done a lot of work as far as moving payers and providers to value-based payment, but we haven't spent nearly enough time figuring out, okay, once we've done that, what is the new way of actually providing delivery to healthcare? What new opportunities can we actually do to serve our patients better because of the way we're getting paid? So for an example for that would be, let's take the most common chronic illness we see for adults, which is hypertension. Right now, we manage people with hypertension by the fact that they come in and see one of our providers. We measure their blood pressure, we make an adjustment in medication, and they go out. Without knowing, okay, which of that person that walked through the front door is the 25% that their blood pressure was okay till they walked in the front door and they had white coat effect. And now they've walked in the front door, I'm seeing them as a provider, their blood pressure's high, I increase their medication, they walk out the door, they follow my instructions, but it makes them feel worse because when they go back home, their blood pressure actually drops a little bit too low, they're feeling a little weak, they're feeling a little dizzy, so they don't sort of trust the system, they take the medicine intermittently, they come back, and now their blood pressure is even higher. So what do? We keep increasing it. And all that's really driven by the fact that most primary care providers in this country are paid only for seeing patients face to face and only this member of the care team, not that member of the care team. We know from the literature that the most effective way, the best predictor of cardiovascular mortality and morbidity from hypertension is what is their blood pressure at home, particularly what is their blood pressure at night. So instead of us investing in making sure that they can check their blood pressure at night and actually through the patient portal be able to give us those results and manage that patient over the patient portal, which would be much more convenient for the patient and also much more economical. Yeah. We don't do that because we're still paying primary care docs fee for service.
So you've been a chief medical officer, you've helped FQHCs and entities get up the value pathway from full fee for service to a range of value-based payment methodologies, and that's why we wanted to talk to you today. Tell me, what are the sort of cultural elements that are required to get a provider up that value pathway? How do you cultivate that, and what do you need to look for to sort of surface in a provider organization so that they have a culture that will get there?
Yeah, so I think we have a long history of actually quality. So when it comes to quality, I think providers in general are pretty used to saying, okay, these are the metrics that we're going to measure you for. They tend to be hideous metrics around preventive measures, around management of chronic illnesses, to a little extent access. So they're kind of used to that. I think, but value is going beyond that and is going to how do I actually do that within the context of reducing total cost of care. And so a lot of our providers are not used to that. And so what's happened with value-based payments, I think we're disappointed in general with the outcomes of value-based payments. Historically, what happened is the health plan sort of said, okay, I'll manage it, so I'll do the utilization management, I'll do the care management, you just keep doing what you've done. Yeah. That worked to a certain extent, but then now we've driven it down to integrated delivery systems, but they've done the same thing. They've created their governance, they sit up here, but then they still expect the primary care docs and the specialists to do the same thing. And then we wonder why we don't get results. So I think really the next step and what we're seeing is that as those integrated delivery systems are assuming responsibility for total cost of care and not getting the results that they're looking for, is they're going back to sort of say, okay, listen, it's going to take more than us just signing a contract. It's going to take more than us just doing some care management. It's going to take us really looking and sort of saying, how do we align our clinical models with each other across the continuum of care now that we're in this together?
Yeah. You know, regardless of one's politics, I have found that Newt Gingrich has a number of interesting things that come out of his mouth over the years. One of the things he said back in the early 2000s, mid-2000s, was, and I just was sort of dumbstruck at the time because I wasn't sure I believed it, and it turned out to be true. said it will take us a generation to move from paper to electrons in the digitization of the healthcare space. It turned out to be right. Do you think it will take a generation for us to move from fee-for-service to some sort of more commonly accepted value-based payment methodology?
No, I don't think it will. I think if you look, for example, the Medicare just came out with the 2018 Medicare ACO data. And what you see is in the first year, the Medicare ACOs are actually a little more expensive. Then you see that by year 1 and year 2, they're saving about $50 per beneficiary. Then you see year 3, year 4, year 5, and year 6. You continue to see that there is progressive savings. So there is a learning curve to it. I don't think it's a generation. I don't think we as a society can afford for this to take a generation. But there definitely is a learning curve.
So how do providers, what's a good way to capture that delta if you're the provider doing the work that's not a shared savings plan or shared savings model where plans and providers have a hard time agreeing on what is going to be measured. It's maybe not global capitation where they would collect it all, but it's now your health plan. Are there ways to sort of build in savings capture that are different from the sort of full capitation model?
Yeah, so I think one of the challenges has been with the total cost of care contracts is that the integrated delivery system signs those contracts, and then you find out 18 months later whether or not you got something, and that doesn't impact your behavior. So what you're seeing CMS doing, you're seeing the FQHCs doing, you're seeing other payers start to move to say, I have to change the way that we reimburse for primary care services, for example, moving in a way that affects my day-to-day. And yes, we'll marry that with the fact that if you save on total cost of care. So for example, if I change you to a capitated system, so you're seeing several states that have moved their FQHCs, and the FQHCs have been actually the movers for that, to create capitated models that move away from fee-for-service, PPS payment, which is what FQHCs are dependent upon, to a capitated model. You're seeing that with Primary Care First now with CMS, which just released the applications this past week. They're realizing that if I can give you some flexibility on the way that you do primary care, so that no longer is it dependent upon, I'll only reimburse you for face-to-face, and oh, by the way, with this member of the care team, not that member of the care team, that gives them the flexibility to start to provide, say, well, how do I now, with that new flexibility, provide more member convenient access to care, more efficient care, and use that as a way to actually develop a marketing edge. So I think as we move it down to the actual practitioner, instead of, again, staying up here or saying that, hey, maybe something in the remote future, that doesn't change people's behavior.
Yeah. I wonder what your opinion on this sort of question is, which is when the ACA passed in 2010, a lot of people said, that's not going to change too much, but it's going to catalyze a number of things that are already in place. I don't know if that's true or not in hindsight, but do you think that this value-based payment conversation was really driven by the Medicare ACOs and the consequent things in MACRA that came out of CMS leading? Or is this something that was already underway, that the market was already doing, that there was some policy catalyzation, but for the most part it was parallel or separate?
Yeah, I think it was parallel to what the commercial payers were already moving towards. So yes, the funding of the Innovation Center, there were lots of demonstrations that CMMI tried. A lot of them didn't turn out to give the savings they were looking for, but they kept trying. I think with the state innovation model funding that went to many of the states around the country, allowed the states to be those incubators. But at the same time, the private sector was moving that direction. So if you saw a study that Avalier published this summer, they looked at 50 of the larger payers in the country, and they're definitely increasingly moving towards value-based payment. They went from their survey in 2017, which showed only a quarter of them were really invested in advanced APMs. Now it's over 50%. And if you look at when they surveyed them and said, well, why are you doing it? The two biggest reasons they were doing it is because they were getting cost savings and they were getting quality outcomes. But what you don't see that in the literature is because that's sort of the secret sauce. Yeah. So a lot of what's kind of going on behind the scenes are really commercial payers that are experimenting having some successes, having some failures, learning from those failures. But you won't see that because it doesn't get posted like CMS does or it doesn't get published in the literature.
Yeah.
But there's clearly a reason that there's a trend that commercial payers are doing as well.
I wish, I'd love to see a world that was a value-based payment world, and I hope nobody deals with PPS and APM methodology determinations because that's a headache. In about 30 seconds, what advice would you give to folks who are trying to explore this, either on the provider side, the payer side, maybe the CBO side? What advice would you give for a group that's trying to move into the value world?
Yeah, I think one of the reasons we're starting to see better results is the fact that you have to be able to collect data in a timely fashion, share data in a timely fashion, and use analytics to inform you. And so the older days of sort of saying, well, I'm going to look at my data, I'm going to hypothesize, and I'll test and find out a year later if it worked or not, are gone. So we're seeing a really acceleration of machine learning that's taking in multiple sources of data, no longer just your medical claims data or even your pharmacy claims data. It's starting to take in real-time data from the hospitals when those patients hit it. It's taking in health risk assessment data off your care management platform, including collecting social determinants of health. So I think that and you really need to make the investment in those analytics and warehousing to be able to inform, and then creating the clinical committees and workforce sort of saying, okay, if I'm trying to reduce transitions of care, let's have the stakeholders around the table and coming up with those models. It has to be informed by the data. So I think that making sure you're making the necessary investment in analytics connectivity is really important.
Good. Art Jones from Dr. Art Jones from HMA. Thank you, sir, for joining us. Give him a round of applause.